Hey everyone, it's Connor here from Durham Hearing Specialist. I hope you're doing well, and in this video I'm going to be answering your top 3 questions that you submitted to me on social media about tinnitus. So let's get started. The most common question that we got, which is sort of a two-parter really, is what is tinnitus and is it dangerous? The first part of the question is quite easy. Tinnitus is anything that you can hear that doesn't have an external sound source, so only you can hear it. It is subjective, and that can take the form of buzzing, whooshing, hissing, static, ringing, whistling, really anything. A lot of the time patients struggle to describe it to me because it is so unique and personal to them. There is technically a second type of tinnitus called objective tinnitus, where if you actually get close enough to the patient, you can hear it as well. It's often in the form of clicking, but this is incredibly rare, and it's often to do with muscle spasms actually above your soft palate, which can be medically managed. So the chances are, if you have tinnitus, you almost certainly have the subjective type. The second part of the question, is it dangerous? For the most part, no. It doesn't mean that there's anything wrong with you or you have a terrible disease or anything bad is going to happen. The only times we would worry are, A, if the tinnitus is, coinciding with other worrying symptoms like visual disturbances and vertigo and nausea and things like that. But those would be the type of symptoms that would make you present to a doctor anyway. The other times would be B, if it's monolateral or unilateral, so you don't hear it in both ears or in the center of your head, it is very much slumped to one side. Then we would refer to ENT, and the ENT doctor would almost certainly order an MRI scan, which more often than not comes back clean, and the doctor diagnoses it as benign tinnitus anyway. If it's pulsatile, so it's in time with your heartbeat, then the doctor might also order a Doppler scan, and a Doppler is an ultrasound of the veins and arteries in your neck. And basically what they're looking for is any areas of turbulence. So that could be turbulent blood flow created by a narrowing or a compression or an outpouching in your jugular vein or your sigmoid sinus or your internal carotid artery, something like that, which can also be medically managed. The second most common question, which I can see coming, is what's the cause? Now, I suppose if you want to drill down into the nitty-gritty of it and you research it, you will see lots and lots of different causes. The list is quite extensive, but when you look down the list, what you'll see is that most identifiable causes of tinnitus are to do with very rare medical conditions, or they're very situational. So tinnitus can be caused by Meniere's disease, by taking drugs with lots of heavy metals in them like cisplatin, or taking ridiculously high doses of aspirin and so on and so forth, or spasming of the middle ear muscles, or what we call middle ear myoclonus. Most people who have tinnitus don't have any of these things, and most people who have it fall into either two categories. The two categories are the deafferentation type of tinnitus and the central type. What the heck does that mean? The deafferentation type, which in my experience is more common, is where the brain is overcompensating for a lack of hearing. A lot of people who fall into this category don't feel like they have any hearing loss at all, but they may actually have some hidden hearing loss further up the spectrum beyond what a normal hearing test would reach. Typically, if we're testing someone's hearing for an ear, nose and throat doctor or to fit a hearing aid, we'll test up to 8,000 hertz. But actually for a tinnitus patient, we tend to test much higher, up to 16,000, which near enough covers the range of full adult hearing. What happens in the deafferentation type is that the brain realizes that there is a lack of input from your cochlea up to your auditory cortex, which is the hearing part of the brain. The cochlea is the inner ear, where all of those lovely sound vibrations are converted into electricity. So it's your inner ear that's creating those nerve impulses. What happens over time is, as you accumulate hearing loss, whether it's over time or due to noise damage or suddenly because something has happened to you, the brain realizes that there's a lack of input. It's not getting that lovely electrical stimulation to certain parts of the auditory cortex. And we think that the brain tries to compensate for that by making those neurons or those neural networks more sensitive. Now, exactly how it does this, we're not entirely sure. It may be that the neurons that are no longer receiving that lovely hearing input wire together more densely, perhaps, because neurons that wire together fire together, or the brain may take away or repurpose some of the inhibitory neurons that dampen down activity. There's a tipping point where those neurons start to fire via themselves in synchronicity, and that's what we think gives rise to this deafferentation type. You'll often find that people in this category, they present with a sort of monotonal tinnitus. So it's like they'll say that it's a ringing or a whistling or a humming or just like a tone, but there is almost certainly a definitive sort of center frequency or center pitch characteristic to the tinnitus. And surprise, surprise, if you do a full audiogram from 125 hertz, which is very low, to 16,000 hertz, and pitch match the tinnitus, you will often find that the pitch match is exactly where the audiogram kind of slumps down the most. The central type of tinnitus is less common, but common enough. In fact, a lot of patients are in both categories, really. And the central type is usually born of an acute or prolonged stress response. And patients with a central type of tinnitus, I tend to find that they present with more of a broadband tinnitus sound. So it's not monotonal, it's more like a whooshing or a static, or it can actually be very difficult for them to describe. What we think happens here is that there is a lowering of auditory filters. Now, if you think about your auditory system, which is a live system, if you put in a soundproof room, the world's best soundproof room, there is still neural activity going on. There is a baseline rate of firing of those neurons, okay? So if you're in a soundproof room, your auditory system doesn't go dead. There is activity there, underlying activity. If you're put in a fight or flight response mode, so you're stressed, your brain is scanning for threats in the environment, particularly auditory threats, then we think that your brain lowers or deactivates in some way your central filters. So these are auditory filters that are normally in place to stop you noticing certain things that are not particularly harmful or worrying. So for example, the rubbing of your clothes, the sound of your footsteps, the sound of your breathing, okay? But because you're caught in this fight or flight response for too long or in a very acute phase, if your brain lowers those auditory filters to try and make you aware of the environment and so on and so forth, you might end up hearing the internal noise of the auditory system. If you have a guitar amp and there's nothing attached, there's no guitar plugged in, but you crank up the volume to 11, then you will start to hear the hiss of the electrical circuitry inside the guitar amp. Same thing with a PA system or any kind of speaker system. But that's a kind of, I think, a good analogy. You've essentially cranked up the volume on that PA system and you're hearing that hiss. Well, the same thing is true of the auditory system, but the auditory system has turned off all those filters and you're now hearing that internal noise. Interestingly, with central tinnitus patients, if you take a history and you say, okay, tell me about your life, what happened 12 months prior to you developing the tinnitus, they will often, they will nearly always report that they have gone through some very stressful events, or a prolonged stressful event like caring for a loved one or a bereavement, or they've lost their job, or something has happened to them which has made them extremely stressed and anxious and worried. The third most common question we got is what can be done? Or in other words, a lot of people asked us, is there a cure? And the short answer is no, there is no cure. The long answer, and this is more of an opinion piece here, is that whilst there's no cure, we can do things which are nearly as good as a cure. Let me explain. There's no drug or jab or operation to turn the tinnitus into silence. That doesn't exist, but there are things that we can do to take your tinnitus from, say, if it's a 9 or a 10 or an 8, and it's really in your face, it's impacting on your daily life, it's stressing you out, it's annoying, and it's really starting to grate and get in the way of your enjoyment of life. We can take that tinnitus from an 8 or a 9 down to a 2 or a 3. That's realistic. Now, we can't turn it into silence, but then again, that's not particularly normal anyway. In fact, if you took 100 people who don't particularly report any annoying tinnitus and you put them in a soundproof room, nearly all of them will start to hear some tinnitus sound at some point. So to totally turn off your auditory system and make it a zero, we can't do that. But we can reduce it. We can lower the perception of the tinnitus. Right now, at least in the UK, there are 3 preferred methods, and they are CBT, or cognitive behavioural therapy, sound therapy, and linear therapy. Cognitive behavioural therapy, I don't know too much about it, to be frank with you, and I'm not trained to deliver it either. Now, if you go and see a proper cognitive behavioural therapist, they will have actually received quite a lot of in-depth training and specialist knowledge to deliver that. The gist of it is that cognitive behavioural therapy is trying to target the negative emotional response that you have to the tinnitus, and it's going to train you to recognise when you're having those negative emotional thoughts, and you've got to stop yourself from doing that and actually rationalise it. So if, for example, you're hearing your tinnitus and you say, I'm never going to experience silence again, this is ruining my life, I cannot cope anymore, this is awful. The therapist would train you to catch yourself in that moment and think, whoa, hang on, the tinnitus is just a sound. It's just a sound. It has no bearing whatsoever on my ability to enjoy life. I'm in control, not the sound. I'm in control of my own happiness. And by doing that over time, the tinnitus perception actually lowers and the tinnitus symptoms actually improve. Now, if that all sounds a bit like psychological mumbo jumbo, believe it or not, CBT is a well-researched and well-validated method for managing tinnitus. It's got lots of research proving that it's effective. Moving on to sound therapy. Sound therapy is actually an umbrella term used to describe lots of different strategies that audiologists, such as myself, employ. You'll sit down with the audiologist, they'll test your hearing, they'll talk a little bit about the tinnitus and provide some counselling, sort of like CBT, but very few audiologists are properly trained and accredited to provide true CBT, but we will provide counselling. And more often than not, they will give you a pair of sound therapy devices. Now, they look like hearing aids most of the time because, well, they are. Most hearing aids actually double up as sound therapy devices. What we might do is, particularly if you have that monotonal tinnitus that I mentioned in the deafferentation category, is we'll find the pitch of your tinnitus and then we will program those devices to sort of produce a sort of narrow band noise which is roughly attuned to the pitch of your tinnitus, but we won't program the devices to cover your tinnitus. We don't actually want to mask the tinnitus. We want to find that lovely mix point where you can still hear it, but you can also hear that sound therapy noise. What happens over time is that it desensitizes the brain to the tinnitus, and again, it's going to break down that negative emotional response, which is reinforcing the perception of your tinnitus, and then over time, normally takes anything from sort of 4 to 6 months, the tinnitus symptoms and the tinnitus perception should lower. The third treatment strategy is called linear, which is relatively new to the scene, but it's been around for 4 years actually, but it's been tightly controlled by the company that owns it, Neuromod, as it's been going through clinical trials and it's now got FDA approval and so on. But initial results are very, very good. So research tells us that linear is effective for about 80 to 91% of patients that go through the 12-week program. The way it works is you listen to specialized sounds through the headphones, which are customized by your audiologist, and at the same time you're going through that, there's a small electrical current that's passed through the front third of the tongue, which is stimulating your trigeminal nerve. This is called bimodal neuromodulation. So by stimulating the trigeminal nerve and the auditory nerve at the same time, and those two pathways are quite heavily intertwined, what it's trying to do is, in a shorter amount of time compared to CBT or sound therapy, trying to lower your tinnitus perception. I'll talk more about linear in a future video, but the initial results are very, very encouraging, and it may be a more viable option for people who don't respond to CBT or sound therapy or simply don't want to comply with those treatment options. So there we go. Those are my responses to your top 3 questions that you asked me on social media. If you have any questions about tinnitus, leave them down in the comments section below and I will try my very best to get back to you. And if you want to see me talk a little bit more about certain topics in a future video, then also let me know. I'll see you on the next video.